Okay, good day nurses. So for today, we will talk about your diabetes mellitus. And when we say diabetes mellitus, guys, ano ba ang nangyayari dito? Mataas ang iyong blood sugar level. Okay? So pag-usapan natin si pancreas, since siya ang responsible for your blood sugar level, specifically si islet of Langerhans. Okay? Your islet of Langerhans, kasi guys, nagpo-produce yan ng tatlong cell. That's your alpha cell, beta cell, and your delta cell na tinatawag. Okay? But we will just focus on the alpha cell and beta cell. Okay, your alpha cell, guys, releases glucagon, thus increasing your blood sugar level. Okay, si beta cell naman, guys, nagre-release siya ng insulin. Anong ginagawa niya? Pinapababa niya ang iyong blood sugar level. Okay, so your normal blood sugar level, guys, is 80 to 120 milligram per deciliter. But some book, guys, says 70 to 110 milligram per deciliter. Okay, for us to be safe, guys, gawin na lang natin siyang 70 to 120 milligram per deciliter. Okay, so paano siya nangyayari? This is your insulin, this is your cell, and this is your blood vessel, okay? Si insulin, guys, will transport the glucose into the cell. For example, nag-intake ka ng carbohydrates, right? Okay, and si carbohydrates, convert siya into glucose. So, may glucose ka ngayon doon sa blood vessel mo. Now, si insulin mo, guys, ita-transport niya si glucose mo to enter cell para may magamit yung katawan mo, guys, na energy. Kasi yung glucose na tinransport ni insulin papunta kay cell, guys, will turn into energy para may magamit yung katawan mo na energy. Ano pa, guys, ang ginagawa niya? Si insulin, guys, tinatransport niya rin si glucose sa liver mo. Okay? For storage. Para in case, guys, na mag-hypoglycemia, si patient, guys, meron siyang gamitin or meron siyang makukuhanan ng glucose mo. Okay, paano nangyari yun, guys? The glucose or the insulin will convert the glucose into glycogen. Okay? And that's what we call the glycogenesis na tinatawag. Okay? So, the glycogen, guys, will store into your liver. So, that pag in case of hypoglycemia, guys, na ma-experience si patient, the alpha cell will activate. Okay? Then si alpha cell, sabi natin kanina na it releases glucagon, right? Thus increasing, guys, the blood sugar or the glucose of the patient. And the conversion of your glycogen into glucose, guys, that's what we call the glycogenolysis. Okay? And we all know naman, guys, that the source of your glucose, guys, is from the carbohydrates. Okay? And pag fats naman, guys, naka-convert yan into fatty acids, right? And pag protein naman, guys, naka-convert yan into amino acid. Okay? And since matalino ang katawan natin, guys, meron din tayong tinatawag na gluconeogenesis. Okay? When we say gluco, it means sugar. When we say neo, it means new, right? Then when we say genesis, formation. So, it is a sugar formation from a new source. Yun yung ibig niyang sabihin. Specifically from fats and protein. Kasi originally, ang glucose is from carbohydrates, right? So, that's your gluconeogenesis. And madidiscuss natin siya later on kay DKA. Okay? Now, let's talk about the type 1 diabetes mellitus and your type 2 diabetes mellitus. Okay? When we say type 1 diabetes mellitus, it is a autoimmune disease diabetes mellitus, guys. So, heredity-related diabetes mellitus siya. And si type 2 diabetes mellitus naman siya, guys, is dietary-related DM or lifestyle-related diabetes mellitus siya. Okay, so what is the problem, guys, in terms of type 1 diabetes mellitus? Zero insulin. So, as in this, literal na zero ang insulin. Walang insulin. Kay type 2 diabetes mellitus, guys, merong insulin, but it is resistant. Okay? Okay, what is the manifestation, guys, kay type 1 diabetes mellitus? Thin ang patient natin dyan, guys. Okay? Kay type 2 diabetes mellitus naman, guys, is obese ang patient natin. Okay? And in terms of blood sugar level, guys, kay type 1 diabetes mellitus, unstable yan, guys. Specifically, tumataas ang blood sugar level kasi, guys, pag may infection or may illness na na-experience ang patient natin na may type 1 diabetes mellitus. Kay type 2 diabetes mellitus naman, guys, is stable na mataas ang blood sugar level yan. Kasi nga, guys, lifestyle-related DM siya. Okay? And the complication, guys, ng type 1 diabetes mellitus, nandyan yung tinatawag natin na DKA or the diabetic ketoacidosis. And kay type 2 DM naman, guys, nandyan si HHNC or HHNS na tinatawag. And pag pinag-usapan natin si diabetes mellitus, guys, alam nyo na kung ano yung manifestation, right? That's your 3Ps, your polyuria, polyphagia, and polydipsia. Okay? Pag-usapan natin siya ngayon, guys, kung bakit nagkakaroon ng polyuria, polydipsia, and polyphagia ang isang patient na may diabetes mellitus. Okay? When we say diabetes mellitus, pag may diabetes mellitus ka, guys, ibig sabihin mataas ang glucose mo. Right? Mataas ang glucose mo. Kapag mataas ang glucose mo or sugar mo doon sa blood mo, guys, anong nangyayari sa blood mo? Nagiging viscous. Okay? nagiging viscous. Increasing now guys, the osmolarity. So ano bang nangyari? Pag viscous ang blood mo guys, nagiging concentrated yung mga solutes. Okay? One of the example of your solutes guys is your glucose. Okay? So, mataas ang osmolarity or increase ang osmolarity, causing fluid shifting guys. And when we say osmolarity guys, that is the movement of water into lower concentration to higher concentration. Okay? O, di ba sinabi natin kayo na pag increase ang glucose, nagiging viscous, and pag viscous ang blood mo, tumataas ang concentration. Right? Nagiging concentrated yung mga solutes, specifically your glucose. Okay? So, mataas ang concentration sa blood vessel mo. Okay, now, anong nangyayari dun sa cell, guys? Yung mga water inside your cell, guys, or from your intracellular space, guys, with the means of osmolarity, guys, is nagmo-move yung water from lower concentration to higher concentration. Okay? Resulting fluid shifting. So, mas madami ng fluid ngayon doon sa blood vessel mo, causing you now guys to have fluid volume excess. Okay? And when we say, pag mataas ang fluid doon sa katawan mo, or there is a excess of fluid volume guys, di ba sinabi natin, mataas din ang pressure, right? Increasing your heart rate now. And 20% of blood guys goes to our kidney. Okay? So, as a result, there will be a increased pressure towards the kidney. Okay? And as the patient urinates, guys, sumasama yung glucose. That's what we call the glucosuria. Because glucose can exert its own osmotic pressure. Meaning, guys, the water follows the glucose. Okay? That follows the glucose, causing you now, guys, to have polyuria. Okay? What else guys? Si polydipsia naman ang pag-usapan natin. Di ba kanina sabi natin na nag-increase ang glucose mo, then therefore nagkakaroon ng viscous o nagiging viscous yung blood mo. Okay, so there is a movement of water from your intracellular to your intravascular, right? So your nagkakaroon tuloy ngayon ng intracellular dehydration na tinatawag. And dito guys, that's your extracellular na tinatawag. So, hindi lang pala from intracellular kumukuha ng water guys. Kumukuha rin siya dito sa extracellular mo. So, causing you now guys to have extracellular dehydration. And that's what we call total dehydration of our cell. Okay? And basically guys, dehydrated si patient. Okay? So, as a defense mechanism of our body guys against dehydration guys, yung nagiging thirsty si patient. Nagiging thirsty siya. And that's what we call polydipsia. Okay, now, you understand kung saan nanggagaling si polyuria, right? From osmotic diuresis or glucosuria. And si polydipsia naman, guys, from total dehydration of your cell. How about si polyphagia? Okay, from cellular starvation siya. Okay, paano nangyayari yun, guys? Diba? Dun sa blood vessel mo, there is glucose. Then, supposedly, diba? There is insulin sana na magtra-transport ng glucose doon sa cell. Pero kay DM1 guys, there is no insulin daw guys. There is no insulin. And kay DM2, merong insulin guys, but there is a resistant. So, konti ang glucose na nakakapunta doon sa cell. Or kay DM1 naman guys, literal na walang glucose na nakakapunta kay cell. So, sa cell mo guys, no glucose. So, kapag walang glucose ang cell mo guys, then your cell guys will starve. Okay? And magmamanifest sa body mo guys, weak ka or no energy. Okay? Then, as a result guys, your body will activate the primary compensatory mechanism. Okay? And the primary compensation against starvation guys is the hunger. Or yan na yung tinatawag natin na polyphagia. Okay? Polyphagia. And dito na mag-i-stop si DM2. Okay? Si DM2. Okay, how about kay DM1? Okay? 'Di ba? Kapag there is polyphagia na nangyari, excessive hunger or extreme hunger na nangyari kay patient, ano ang management mo? Supposedly, gagamitan natin siya ng subcutaneous insulin. Okay? What if kay DM1, hindi natin siya nabigyan ng insulin? Anong mangyayari? It activates your secondary defense against cellular starvation. So, anong gagawin niya? Magre-release siya ngayon ng glucocorticoids, guys. We all know naman, guys, the glucocorticoids, guys, increases your blood glucose. Okay? So, there will be gluconeogenesis na mangyayari. Ano yun, guys? Diba sinabi natin kanina, guys, na it is a form of glucose from a new source. Right? So, ano ang gagamitin niya as a source, guys? From fats and your protein. Okay, for example, kinonvert niya si protein into glucose, guys. Anong mangyayari? Mas mag-i-increase ngayon yung glucose, causing you now, guys, to have hyperglycemia. Okay? How about naman, guys, pag kinonvert niya yung fats into glucose, okay, the byproduct of that, guys, is the ketones. Okay? ketones ang byproduct yan. And we all know naman guys, the ketones guys is acidic in nature. So, low ang pH yan guys, causing you now guys to have metabolic acidosis. And dyan na lumalabas yung complication ngayon ni patient guys na diabetic ketoacidosis pag pinag-uusapan natin ang DM1. Okay? So, what are the assessment findings guys kay DKA? Or diabetic ketoacidosis? There will be abdominal pain, okay? And it is global to all acidosis, guys. The smooth muscle will irritate and magkakaroon ng decreased perfusion doon sa GI mo or doon sa gut mo. Then there will be electrolyte imbalance. That's why, guys, nagkakaroon ng nausea, vomiting, and diffuse abdominal pain. Okay? O what else, guys? Weak and ready pulse because of the severe dehydration. Okay? Severe dehydration na nangyayari kay patient. As a result, decrease kasi ang circulating blood volume. So, decrease ang blood volume, then therefore decrease ang cardiac output. And the DKA, guys, it aggravates now the 3Ps. Okay? O what else? Fruity odor breath or acetone breath. Because acetone, guys, is volatile, so it is exhaled through the lungs. Okay? Then, altered level of consciousness, guys. Ketone causes sedation of the brain, causing you now, guys, to have coma or yung tinatawag natin na ketotic coma. Then lastly guys is the cosmos breathing. That is from the compensation guys, blowing off the carbon dioxide kasi nga there is metabolic acidosis na nangyayari. So, di ba sabi natin sa acid-base balance guys na pag metabolic acidosis ka, your respiratory or your lungs guys will compensate, right? Para i-blow off na yung CO2 para i-balance niya sana, okay? So, kaya nagkakaroon ng cosmos breathing. So, what is the management of DKA, guys? IV insulin. Okay? And the only insulin, guys, na pwede sa IV, guys, is that's your regular insulin. Okay? But, you need to watch out for hypoglycemia and hypokalemia. Okay, bakit, guys? Paano nangyayari yun, guys? Diba? Sabi natin, guys, si insulin, guys, will serve as a transportation of your glucose, right? Of your glucose. Pero hindi lang kasi si glucose ang sinasakay niya guys. Sinasama niya rin si potassium papunta kay cell guys. Causing you now guys hypoglycemia and hypokalemia. So you need to watch out for that. Okay, now we move on to your complication ng iyong DM2. Okay? And that is your hyperglycemic, hyperosmolar non-ketotic coma. Okay? Ano ba ang nangyayari dyan? Okay? There is and increase of glucose. And since mataas ang sugar mo doon sa blood mo, yung blood mo ngayon nagiging viscous siya. Okay? Nagiging viscous siya. Increasing now guys, the osmolarity. Okay? Increase glucose, that is hyperglycemic. Then hyper is osmolar, that's from the increased osmolarity. And non-ketotic coma, bakit? I-discuss natin. Okay? Sa HHNC, ang blood sugar level mo is nagre-range from 600 to 1,000 mg per deciliter. So, increase ang iyong blood glucose level. So, pag nangyari yun, there is a fluid shifts from intracellular to intravascular space. Ano ba yung explanation natin kanina? Mataas ang concentration dito, right? Because of the increased viscosity na nangyayari. Nag-i-increase ang concentration as a result of increased osmolarity. So, yung cell mo is yung water mo dito sa cell, nagta-transfer siya doon sa intravascular, okay? From intracellular to intravascular ang nangyayari. Kasi dito sa intravascular mo, higher ang concentration, while dito sa intracellular mo is lower concentration ang meron. So, that's why nagkakaroon ng fluid shift from intracellular to intravascular space, okay? Then, all cells suffer from dehydration. So, lahat ng cell, including the extracellular and including also your brain cell, na de-dehydrate. That's what we call the cerebral dehydration. So, pag nagkaroon ng dehydration doon sa brain mo, then therefore possible mag-lead siya into coma. Okay? So, what is the management, guys? You give hypotonic solution, di ba? From the concept of hyper, pag sinabing hyper, it shrinks. Right? It shrinks. Okay, when we say hypo, it swells. So, since dehydrated ang iyong brain cell, kailangan mo magbigay ng hypotonic solution para mag-swell. Okay? So, now, what are the chronic complications? Okay, so the problem is, di ba, mataas ang sugar level, so increase ang viscosity. Now, anong nangyayari doon sa blood flow? Nagiging sluggish siya. Di ba? Kasi nagiging viscous ang blood mo. So, as a result, magkakos siya ng endothelial damage. Okay? Why? Because the glucose sticks to vessel walls. Now, nadadamage siya yung endothelium, causing now guys to have inflammation. As a result, magtitiken ang capillary basement membrane mo. So, magnanaro ngayon ang vessel lumen mo. leading to LDL deposition and plaque formation. Okay? So, may nangyayaring chronic tissue ischemia. Okay? Then, since sluggish ang blood flow, it will lead to problems on macro and micro circulation. So, habang nangyayari lahat ng yan, pwedeng mag-lead into hypertension because of the narrow vessel lumen. Okay? And atherosclerosis naman guys, from the narrow vessel lumen also, di ba sabi natin there is a deposition of your LDA and plaque formation. So, kapag nangyari yun, it could lead to your stroke, MI, and angina, and the peripheral venous disease. Okay? O what else? Nephropathy guys, because of the thickening of the glomerular basement membrane. Okay? Then diabetic impotence naman guys, because of the decrease, since sluggish ang blood flow guys, nagdi-decrease ang blood flow doon sa penile mo, causing you now guys to have diabetic impotence. Okay? Then diabetic ulcers naman guys, from ischemia and sensory loss. Okay? Diba nagkaroon ng ischemia, then therefore konti ang blood flow na dumadaloy doon sa foot mo or sa feet mo. Okay? Then therefore kung konti ang dumadaloy na blood doon, nagkakaroon ngayon ng sensory loss na tinatawag. Okay? Then retinopathy or blindness. Diba? Siyempre, kung kulang ang blood flow papunta doon sa vessels ng eyes mo, then therefore possible mag-turn into blindness. Then neuropathy, lastly, the neuropathy naman guys is the loss of sensation because of the sluggish blood flow. Kapag sluggish kasi guys, nagkakaroon ng problems on macro and micro circulation. Okay? And that's all for your complications.
Now, we will now discuss your intervention and patient teaching to those patients who has a diabetes mellitus. Okay, intervention for diabetes focus on one, which is achieving a glycemic control through a combination of lifestyle modifications and medications. Then our patient teaching is to prevent complications. So the first light treatment for DM are diet, exercise, weight loss, and plus insulin for type 1 DM. Okay? Yan yung first line treatment guys. So for glycemic control, we need to monitor the hemoglobin A1C. Okay? The hemoglobin A1C percentage represent the average glucose level for the past 3 months. So na-measure niya guys yung blood sugar level mo for the past 3 months. Ganun siya ka-accurate. Okay? Now, madadiagnose ka ng DM kapag ang result ng hemoglobin A1C mo is greater or equal than 6.5%. Yan, madadiagnose ka na may DM ka. Now, kapag may DM ka na, ang goal mo, ang treatment goal mo is dapat yung hemoglobin A1C mo is less than or equal than 7.0%. Diyan lang dapat. Yan ang treatment goal mo if you have DM. Okay? Now, let's talk about your diet. Okay, the diet of a patient is individualized for weight loss. Parang care plan lang din guys. It is individualized. Okay, we choose fruits and vegetable instead of simple empty carbohydrates like white bread and sugary beverages. Okay, we can also do carbohydrate counting. So we count the carbohydrate intakes we take every day. Okay, it required for clients taking a high dose of insulin. For the exercise naman, exercise improve glycemic control. It also support weight loss, and exercise decreases cardiovascular risk. Okay. Perform moderate activities such as brisk walk at least 150 minutes per week. Okay, you need to monitor your glucose before, during, and after exercise. Now, ang gagawin mo guys, kailangan kumain ka 1 hour before exercise. At mag-e-exercise ka naman guys when the blood glucose levels are peaking. Kung mataas guys yung blood glucose mo, you do exercise. And then, clients should not exercise if they have ketonuria. Kapag presence yung ketones nila in the urine, or they cannot exercise when they have a severe hyperglycemia. Gano ka severe? Greater than 200 mg per deciliter or greater than 13.9 millimol per liter. Then, during exercise, guys, you need to wear your identification bracelet para alam ng ibang tao na may DM ka. And you need to carry a fast-acting carbohydrate source. Okay, ano yung mga fast-acting carbohydrate source? Like orange juice, regular Coke, and so on and so forth. Okay? Then, teaching naman tayo. We teach the client how to check glucose. Okay, guys, since magre-ret them naman kayo using your glucometer, magkakaiba yan depending on the brand of the glucometer, okay? But this is the principle on how to check your glucose. First, hand hygiene. Wash hands before and after. You need to follow the manufacturer instruction kasi depending yan sa brand ng glucometer mo. For decalibration and strip expiration date, okay? Do not share or reuse the lancet. If result seems incorrect, check technique and strip expiration, then repeat the measurement. Okay, so skills nyo na to yan guys, ma-emphasize. Okay, now, let's compare the signs of hypo and hyperglycemia. Ano ba ang mas malala? Mas malala, is it hypoglycemia or hyperglycemia? Pag hypoglycemia yan, guys, cold and clammy si patient. Cold and clammy needs some candy. Pag hyperglycemia guys, ano naman nangyari kay patient? Hot and dry. The sugar is high. Okay. Hypoglycemia, confused si patient since wala siyang glucose, irritable siya, tremors, diaphoresis, palpitations, tachycardia. Like guys, yung nagpapawis siya ng malamig. And if severe guys, it can lead to seizure, coma, and death. And then sa hypoglycemia naman, ang signs ng hyperglycemia, lethargic si patient dyan, hot, flush, dry skin, yung 3Ps which are polydipsia, polyphagia, and polyuria. And if severe naman guys, leading to DKA, one manifestation is fruity breath. So, now you know that mas dangerous or delikado ang hypoglycemia of that hyperglycemia. Okay, now, management muna tayo ng hypoglycemia. Okay, hypoglycemia is more dangerous, as I have said earlier, than hyperglycemia because it can cause permanent neuron death and seizure. If there is no glucometer, yung pang-measure ng blood glucose guys, if walang glucometer na available to discern if it's hyper or hypoglycemia, you need to assume that the client has hypoglycemia. I-assume mo guys na may hypoglycemia since mas dangerous siya compared to your hyperglycemia. And then check the blood sugar for any client with an acute change in mental status. Guys, pag napansin mo may acute changes in the mental status of the patient, kunyari naging confused siya, hindi niya alam kung nasan siya, naging disoriented siya, okay? You need to check the blood glucose of the patient kasi possible na nagha-hypogly na siya. Then, treatment follows the rule of 5. Ito ang treatment ng hypoglycemia, guys. You need to give 15 grams of carbohydrates and recheck glucose in 15 minutes. Again, emphasize ko guys, pag napansin mo na may acute changes in the mental status of your patient, kapag naging disoriented siya, confused, i-assume mo na meron siyang hypoglycemia. Then treatment follows rule of 15 grams of carbohydrates plus recheck the glucose in 15 minutes. Now, paano natin yun ginagawa? Okay. Now, is the client alert enough to swallow? Siyempre guys, kung conscious si patient, tatanungin mo muna kung, or you need to think if kaya niyang iswallow or kaya niyang kumain ng 15 grams of carbohydrates. Kasi what if unconscious si patient o di hindi niya kayang iswallow yung 15 grams of carbohydrate? Then if the patient is alert, give the 15 grams of carbohydrate. Okay, for example guys, it is not necessary naman na ito lahat. For example lang guys is 1/2 cup of juice or non-diet soda. Then 5 lifesavers candies, 1 teaspoon or 15 ml of honey and glucose tab or gel. Okay, 15 grams na yan guys. Then recheck in 15 minutes. Recheck mo yung blood glucose niya. Then repeat the dose as needed. And then after sugar stabilize, kapag nag-stabilize na yung sugar niya, you need to give the patient a snack with carbs plus proteins. For example, crackers and peanut butter. What if naman unconscious or confused si patient? Okay, so hindi niya kayang kainin yung 15 grams na carbohydrate. Now, the management is, you need to inject glucagon IM. So, IM ang pag-inject ng glucagon. Or you need to give 50% dextrose IV. Now, you know that 15% of dextrose contains sugar. So, kaya IV siya. Okay? Then, after giving this to either of these two, you turn the client to one side. Okay? Left side lying, okay, if giving glucagon because it can cause nausea. And then recheck in 15 minutes plus repeat the dose as needed. Then you notify the healthcare provider. Now, you do not ever give fatty foods like ice cream, candy bar, and whole milk because fat slows the glucose absorption. Yan yung ice cream guys, candy bars, and whole milk, rich in fats yan guys. Then fats now slows the glucose absorption. Then do not give large amount of sugar because it can cause hyperglycemia naman. Okay? Then we teach the importance of glycemic control to prevent complication of widespread vascular damage. Yung na pag-usapan natin kanina about the micro and macro circulation problems. Okay, like your atherosclerosis, MI, or CVA stroke. For wound healing, so the client with diabetes need a tight glucose control after surgery. And then si client, may increased risk din siya for infection, retinopathy. So the patient needs annual eye exam for screening by an ophthalmologist. And for peripheral neuropathy, meticulous foot care to prevent diabetic foot wound. So, paano ba yung diabetic foot care natin? So, we need to teach the client to inspect the feet daily. Daily yan para ma-notice mo kung may changes doon sa diabetic foot mo with a mirror. Then, dry the feet thoroughly. Dapat dry yan, hindi siya moist because moist is a good medium for bacteria to grow. So, dapat dry the feet thoroughly. No soaking the feet in water or do not apply lotion between the toes. Then, wear a well-fitted closed-toe shoes. No bare feet, tight shoes, or open toe shoes like flip-flops. Then, you cut the toenails straight across. Straight ang pagkat ng nails guys. Toenails guys, hindi yung pa-curve. Okay? And don't use heating pans since may sensory loss na si patient dyan. Baka hindi niya na alam na burn na yung paa niya. Okay? So, you do not use heating pads. Now guys, for the medications, okay, insulin ang medication dyan. Or oral diabetes medication. Okay, insulin is given and it is always indicated in type 1 diabetes mellitus. So, insulin is para kay type 1 diabetes lang siya. But, it may be indicated in your type 2 DM if it severe, okay? Then your oral diabetes medication naman guys is only effective in your type 2 DM because insulin is still produced, diba? Resistant lang siya. So, ang management dyan is oral diabetic medications, okay? Let's talk first about your oral diabetes medications. Then, anong ginagawa ni oral diabetes medication? Guys, madaming mechanism. It decreases your glucose using various mechanism. Okay, meron yung gamot na ini-increase niya ang insulin secretion from the pancreas. Meron din yung mga gamot na dinedecrease niya yung glucose output from the liver. Mamaya, we will talk kung sino yung mga specific na gamot na yan. And then, multiple classes are often given in combination to achieve the hemoglobin A1C of less than 7.0%. Now, let us talk about your oral diabetes medications. Okay, we have here your biguanides. Example of your biguanides is metformin, which is the first line for type 2 diabetes. So, anong mechanism of action ni biguanides? It decreases your glucose output from the liver. So, binababa niya yung glucose output from the liver. Okay? Then, one important nursing consideration when taking metformin is to hold the metformin for 48 hours before IV contrast. So, kung mag-undergo si patient ng IV contrast as nagtitake siya ng metformin, you need to hold the medication for at least 48 hours before IV contrast to prevent lactic acidosis. Okay? Another one, we have your, mahihirap siyang bigkasin guys. Itong mga to, we have your dulaglutid, semaglutid, which is incretins. Okay? Meron din sitagliptin and sasagliptin, which are the DPP4 or dipeptyl peptidase 4 inhibitors. Okay, anong ginagawa ng mga gamot na ito? It decreases your glucagon secretion. Okay, slow gastric emptying and aids in weight loss. So, may tumutulong din siya to lose weight. Okay, basta ang main mechanism of action yan, dinedecrease niya yung glucagon secretion. You know that glucagon increases your blood sugar. So, dinedecrease niya yung glucagon secretion. Okay, one important consideration is that it can cause pancreatitis. Okay, ini-inflame niya yung pancreas mo. So, you need to report any jaundice or abdominal pain. Another medication is your dapagliflozin and empagliflozin. Okay, anong ginagawa ng mga gamot na to? It increases naman your glucose excretion. So, ini-excrete niya yung glucose mo into the by means of urination. Okay? Now, important consideration is to that this medication increases the risk for vaginal and urinary tract infection naman. Then next is your sulfonylureas. Okay, like your glipizide, glimepiride, and glyburide. Okay, anong ginagawa naman ng sulfonylureas? It increases insulin secretion from the pancreas. Okay, yun yung ginagawa niya. Alam niyo si insulin, pinapababa niya si blood sugar. So, your sulfonylureas, it increases your insulin secretion from pancreas. Okay, important nursing consideration when the patient taking this medication. You hold if the patient is NPO because it can cause hypoglycemia. Kapag NPO si patient, i-hold mo tong mato kasi mas lalo siyang magkukos ng hypoglycemia. And avoid alcohol because it can cause disulfiram-like reaction. Okay, you need to hold alcohol because it can cause disulfiram-like reaction. Now, sa insulin naman, yung insulin treatment natin, you need to take a screenshot on this one, guys. Okay, paano? Kasi ang pinaka-importante dito, alam mo yung onset, peak, and duration, okay, ng insulin. But most importantly, dapat alam mo kung kailan nagpipeak yung insulin. Because kapag nagpeak na yung insulin, this is the delikado kasi dito na makaka-experience si patient ng hypoglycemia. So, you need to know the peak of the insulin. Okay. Okay, first, the legend. Okay, si purple guys, ito si this purple guys, rapid acting insulin. Example of your rapid acting, your Lispro and Aspart. Okay. So, yung onset guys, kung kailan nag-i-start yung effect ng insulin, then yung peak. Yan, yung pinaka-peak. Kailan may experience ni patient yung hypoglycemia. And duration, kung gaano katagal nagte-take effect yung insulin. Then, your orange is the short-acting insulin, which is your regular insulin. Okay, ito naman siya guys. Okay, peak niya dito naman. Okay, your green naman is the intermediate acting or your NPH. Okay, also known as your cloudy insulin. Okay, itong kulay green na to, dito sa graph. Si short-acting insulin, guys, this is your clear insulin. Clear insulin, this one naman is your cloudy insulin. Then your long-acting insulin, this one. Okay, long-acting example is Gardlin. The only insulin that it has no peak time. It has no peak time. So, hindi makakaranas si patient ng hypoglycemia. Okay, dito, focus tayo dito sa table na to. Okay? So, we have here the types of your insulin. Okay. First type is your rapid-acting insulin. Example of your rapid-acting is your Humalog, Lispro, Aspart, and Glulicin. Okay. Then, we have your, the rapid-acting insulin. Okay. Ang onset nyo naman, guys. Okay. Onset, peak, and duration. Okay. Ang onset ng rapid-acting is 15 to 30 minutes. The peak is 1 to 3 hours and the duration is 3 to 4 hours. Again, ano yung pinaka-importante mong malaman dito is the peak time. Okay, kung kailan makakaranas si patient ng hypoglycemia. Okay? Another one is your short-acting insulin or your regular insulin. This is the only insulin that is clear. Clear siya. Okay, this is our clear liquid. Okay, example of your short-acting or regular insulin is your Humulin R and Novolin R. Okay, hindi ka na malilito dahil meron siyang R. Alam mo na siya ay regular insulin. And this is the only insulin that given through IV route. Okay, siya lang si insulin that is given through IV route. Okay, ang onset niya, 30 to 60 minutes. The peak is 2.5 hours and the duration is 6 to 10 hours. Next type is your intermediate or your NPH. Okay, example of this is Humulin R and Humulin N and Novolin N. So, may N dito, NPH. So, alam mo na this is an intermediate insulin, NPH. Also known as your cloudy insulin. Okay, the onset is 1 to 2 hours. The peak is 4 to 12 hours. And the duration is 10 to 18 hours. Now, your long-acting insulin. Okay, example of your long-acting insulin is Glargine and Determir. The onset is 1 to 2 hours. The peak is none. It has no peak time. Okay? Then the duration is 24 hours. Okay, kaya siya long-acting. Now, guys, hirap siya i-memorize, diba? Okay, pero meron naman din trick kung papaano. Okay, dito sa tatlong to. Okay, you need to remember the number 147. 147. Okay, sulat mo na dyan sa onset 1, peak 4, duration 7. Okay, dodoblehin mo lang to pababa. then i-divide mo naman siya dito. Okay, for example, okay, short-acting insulin, ang onset niya is 1, then, dadoblehin mo siya, 1 plus 1, 2, then 2 plus 2, 4. Okay, dito naman, 4. 4 plus 4, 8. Okay, wala siyang peak so wala tayong ilalagay. And then, the duration, dito naman sa duration, 7. Say, 7 plus 7, 14. 14 plus 14, 28. Ngayon, i-divide mo siya. Okay, divide mo. 1. Okay, the half of 1 hour is 30 minutes. Okay, half of 2 hours is 1 hour. Then, half of 4 is 2. Then, dito, 4, half niya is 2. 8, half niya is 4. Then, 7, ang kalahati niya, 3.5. 14 naman is 7. Sa 28 naman, kalahati niya is 14. Now, nakompleto mo na siya. Now, it is not always exact. Okay, depende siya sa choices, sa multiple exam. But, at least, alam mo kung sino yung pinakamalapit. Okay, you choose the pinakamalapit kapag sasagot ka. Okay? At least may pagre-rangean ka. Okay? Okay. Important consideration naman daw sa insulin, guys, that your insulin enables glucose and potassium to enter the cell. Na, alam mo na yun, guys, yung drawing ko, diba? Hindi lang si glucose ang tinatransport niya inside the cell, pati din si potassium. So, tinatransport niya si glucose and potassium inside the cell to enter the cell. And client should start eating. So, kailangan si patient, kapag may insulin siya, start eating na siya before the insulin onset. For example, within 15 minutes of Lispro. Kung Lispro yung insulin niya, kailangan niya kumain na within 15 minutes of Lispro. And other medications consideration, okay guys, you know that your steroids increases your blood sugar. Pag nagtitake ka ng steroid, it increases your blood sugar. And beta blockers can cause hypoglycemic unawareness. Okay? Now, you know that the complication of your type 1 diabetes is DKA. Na-explain na natin yan, di ba? Complication of your type 1 diabetes is DKA. So, expound natin yung treatment niya. Okay? Yung treatment. Our interventions. Okay. The initial interventions for your DKA is to give IV fluid to treat dehydration. This is our number 1 priority. Then, we give IV regular insulin to treat the hyperglycemia and hyperkalemia. Okay? Kasi, di ba, your glucose and potassium can enter the cell. So, you give the regular insulin. Okay? Then, rapid drop in glucose can pull water into the brain, causing to have an increase in ICP. Then, during IV infusion, insulin infusion, we frequently monitor for any mental status, changes in the mental status, glucose, we monitor the glucose level and potassium level during the IV insulin infusion. Yan yung mga imo-monitor mo. With ongoing interventions, ano naman gagawin natin? We frequently monitor the perfusion status. Paano mo malalaman if perfuse ang lahat ng cells mo? You do VS and urine output, tawag dito? The urine output, you measure the urine output. Then check for or monitor for any mental status for an increased ICP. Okay, then the ECG monitoring. Okay, so nakahook dapat si patient into a cardiac monitor para malaman mo yung potassium level niya since mag-enter yung potassium inside the cell. Okay, then next, okay, we check glucose hourly. Every hour tayong check yung glucose niya. Then once glucose fall, pag bumaba na yung glucose level niya into less than or equal than 250 mg per deciliter, kailangan nang i-switch yung IV fluid niya into dextrose or your D5NS. Okay, di ba? Kasi bumaba na yung 250 mg per deciliter yung glucose level niya. Okay? Then we give potassium replacement as needed. Kasi nagha-hypokalemia na si patient dyan. Kasi di ba ang treatment natin, IV, regular insulin. Saan nilagay ni insulin si potassium? Inside the cell. So, pwedeng mag-hypocalcemia si patient. So, we give potassium replacement as needed. And then, dextrose. Kasi, di ba, with glucose na to, kasi possible, nagha-hypogly na din si patient. And then, we give IV, sodium bicarbonate for severe acidosis. Di ba? Metabolic acidosis, ang ABG ni patient kapag may DKA. So, we give IV sodium bicarbonate. Okay? Okay, because of severe acidosis na less than 7. Okay? Diba? So, we give sodium bicarbonate. Then, The treatment naman of your hyperosmolar hyperglycemic syndrome or your HHNS, guys, like this is the complication of your type 2 DM. Anong gagawin natin? Okay, your hyperosmolar hyperglycemic syndrome occurs only in type 2 diabetes where enough circulating insulin is present to prevent DKA. The findings is similar to DKA except, diba, non-ketotic siya, diba, no ketosis, okay, negative for ketones, and normal ang kanyang ABG. It is more severe hyperglycemia because it can reach your blood glucose up to greater than 800 mg per deciliter or greater than 44.5 millimole per liter. Treatment is similar to DKA, IV fluids, IV insulin, and electrolyte replacement. Now, you need to know how to mix insulin since nag-mix tayo ng insulin. Okay, my question is, what is the insulins that can be mixed? Okay, the only insulin that can be mixed is your NPH or your intermediate insulin and your regular or rapid short-acting insulin. Sila lang, guys, ang pwede nating ipag-mix. These two. Okay, sila lang. So, pwede natin ipag-mix si clear insulin, then our cloudy insulin. Okay, sila lang. Si short-acting or regular insulin, then intermediate or your NPH insulin. So, may rule tayo on how to properly mix these two insulin. Basta ang pinaka-principle lang dito, guys, na tatandaan mo is you do not contaminate the clear insulin. Again, let me repeat myself. You do not contaminate the clear insulin. Huwag mo daw i-contaminate si regular or short-acting insulin. So, paano na ngayon tayo mag-mix ng insulin? For example, guys, we mix these two insulin. Okay, in your syringe, kailangan daw natin ng 30 units of mixed insulin. 30 units. Okay. For example, mag-aspirate ako ng 30 units of air. I will aspirate 30 units of air from my syringe. Okay. Then, I will inject the 20 units of air first. I will inject air first to the cloudy or to your NPH. Okay, insert mo yung air, 20 units. Then, alisin mo si syringe. Then, the remaining 10 units of air is then injected to your clear insulin. I-inject mo na yung remaining 10 units of air to your clear insulin. Then, you invert your vial. Invert mo na yung vial. First, that you withdraw is galing kay clear insulin. Ilan yung inintroduce mong air kay clear insulin? 10 units. So, 10 units din ang kukunin nating insulin kay clear insulin. So, we withdraw now 10 units of clear insulin. Okay, withdraw the insulin from clear. Then, tanggalin mo na yung syringe. Then, kunin mo na si cloudy insulin. Inject mo na yung, i-insert mo na yung needle. Insert mo yung needle. Wag mong i-inject I-insert mo lang. Then, invert your vial. Okay? Then, ilan yung inintroduce nating air kay cloudy? 20 units. Okay? Then, we withdraw the 20 units of cloudy insulin. Now, buo na ba yung 30 units natin na insulin? Yes. Tanong, na-contaminate ba natin si clear insulin? No. So, the principle when mixing the insulin is you do not contaminate the clear or regular insulin. Okay? Dito tayo sa subcutaneous heparin administration, guys. Sa ibang bansa, meron ng ganito kasi yung pre-filled syringe. Now, kapag may ganito na, guys, we do not expel the air bubbles from pre-filled syringes. Then, paano tayo mag-a-administer? Okay? We administer it mostly saan? Sa abdomen. Okay, ano yung rule dyan? Inject the medication at least 2 inches or 5 centimeter to the right or left of the umbilicus. So, this is your landmark, the umbilicus. Okay? 2 inches or at least 2 finger breadths. Okay, on the umbilicus. May ganyan, guys. Okay? Then, when injecting insulin, guys, you need to rotate the injection site to prevent what? Okay, ano yung prevent mo? Anong pinaprevent mo? Bakit mo nire-rotate? Okay, when you say rotation, guys, so for example, ngayong gabi, dito ka mag-i-inject. Bukas ng gabi, dito ka naman mag-i-inject. So, you rotate the injection kasi anong iniiwasan mo? What it is, guys. Ano ang iiwasan mo? Why you need to rotate the injection. Okay. Then, dito naman, guys, paano ka bigay ng insulin. Okay, if you can pinch 2 inches or 5 centimeter, you insert the needle at 90 degree angle. Then if you can pitch 1 inch or 2.5 centimeter, you insert at a 45 degree angle. Okay, Dito tayo sa subcutaneous injection site natin. Okay. This is your 90-degree angle and 45-degree angle. Ano yung main site? Ano yung mostly site of injection natin? It is our abdomen. Other injection site, we have the outer aspect of the arm, the front of the thigh, the scapular area of the upper back, and the dorsal gluteal area. Okay. Needle length and insertion angle is based on weight and estimation of the subcutaneous tissue. Again, if you can pinch 2 inches or 5 centimeter, you insert the needle at a 90-degree angle. And then if you can pinch 1 inch or 2.5 centimeter, you insert at 45-degree angle. Now guys, this is your assignment. Okay. To compare the signs and symptoms of diabetes insipidus, your DKA, and your HHNC. Okay, kung present ba si ketone sa diabetes insipidus, sa DKA, or HHNC. Okay, check mo lang yan guys. For example, yan, present siya or hindi. Check or wrong nyo lang siya. Present, check, ganyan. This is your assignment. Okay, that's all for our discussion. Thank you very much and have a nice day, nurses. Okay?